Hello everyone. Today we are going to talk about Valsalva maneuver. It's an important test for the dynamic auscultation as well as for evaluation of cardiac diseases. So Valsalva maneuver is done when a patient exhales deeply, like after taking a deep inspiration, they exhales forcefully into a mercury manometer. Ideally, it has to be done in that way. So the pressure should be such that the pressure of at least they should be able to maintain a pressure of 40 millimeters of mercury for about 20 seconds. So if they maintain that pressure for 20 seconds, then it is actually ideally it has to be the Valsalva maneuver in that way. But sometimes we may not be able to use mercury manometer all the time. So bedside technique, what we do is we ask patient to take a deep inspiration. So he takes a deep inspiration followed by a forced expiration. So we'll ask them to breathe out with a very force against a closed glottis for 20 seconds. So for 20 seconds continuously, he should expire against a closed glottis for 20 seconds. Another important simple way is bedside. We would try to put, as a doctor, you try to put a resistance on the stomach. So here patients take a deep breath and closes the mouth. We ask him to strain, like as he is going to pass the stools or like bowel movements. So we ask the patient to strain in such a way that as he do for passing bowel movements, such a way that he should try to lift our hand, try to push our hand against the resistance, and that actually generates the bedside Valsalva maneuver. So the care has to be taken in patients of any hernia or varicose patients. Okay, so it consists of four phases. So after taking a deep inspiration, whenever the patient is doing the expiration, so this is divided in that way. The first phase is called as the onset of straining. That is the first 10 seconds. First 10 seconds, whenever the patient is expiring with the deep pressures due to the raised intrathoracic pressure, the intrathoracic pressures will be high, raised intrathoracic pressures, and this intrathoracic pressures applies pressures on the aorta. So on the abdominal aorta, there will be compression of the abdominal aorta because of the raised intrathoracic pressure. And since there is compression to the abdominal aorta, the blood pressure will be raised. And to respond to that, the heart rate will be in the reverse direction, that is decrease heart rate in the phase one. Next phase two is the next 20 to 10 to 20 seconds. It is called as the continued expiration phase. So during continued expiration phase, patient is expiring continuously for the next 11 to 20th second. So in this, during this pressure, the venous return also gets compressed. That means the IVC gets compressed. So there will be decreased venous return. So venous return is an important factor for cardiac output. So there will be lesser cardiac output and thus systolic blood pressure will decrease. To respond to that, the heart rate will increase. Always remember that the Valsalva maneuver, usually all the cardiac murmurs or cardiac evaluation we do in this phase only. That is the phase two. So phase two is an important phase where we actually do the examination of the murmurs and cardiac evaluation in during this phase only. Coming to the next thing is the phase three. Here the patient is trying to relieve now, and this phase is now called as end of expiration. So since there was decreased venous return, so all this venous return should come where? It should come to the right atrium from the IVC and then to right ventricle, and then it should go to the lungs, that is pulmonary artery, and finally pulmonary veins. So now the lung is deprived of all the blood and all. So suddenly when we are expiring and close to the end of the expiration, all the blood which is coming back from the venous return because of the decreasing pressure over the IVC. So all this blood will be first taken by the pulmonary venous capacitance. That means that these pulmonary veins will now try to take all the blood which is coming now in initial phase so that they can use it for the gaseous exchange and all. So because since all the blood is used by the pulmonary veins only and it is not going into the systemic circulation much, thus systolic blood pressure will be down only. So as you can see here in the phase 3 end of expiration, the blood pressure will be again raised, will be further decreased actually because the venous return is also not there and all the blood which is coming is also being taken by the pulmonary veins. And the response to that is heart rate also increases. And this phase is called as a phase 3 and this is all end of expiration. Next is the phase of recovery, that is 5 to 10 seconds after stopping of the expiration. What happens because now BP was not there, there will be overshoot. Now overshoot of the sympathetic system. Sympathetic activation overshoot, and all the blood will now come to the direct circulation, and thus increases the cardiac output and contraction, and thus there will be increase in blood pressure during this phase. So phase 1 called onset of strain, there BP is increased due to aortic compression and heart rate is decreased. Phase 2 is the where maximum cardiac evaluation is done. Here, due to decrease in venous return, the BP will drop, heart rate increases. End of expiration, because of the increase in pulmonary bed capacitance, all the blood goes there, so BP will be decreased again because systemic circulation doesn't have much blood. And now BP overshoots in the phase 4, it's called the recovery phase. Okay, so what happens in stage 2 effects on the heart sounds and murmurs? Because there is all the effects is basically because of decrease in the venous return. So because the blood comes less to the heart, all the murmur will become soft. The intensity of murmur decreases of all the murmur except two murmur, that is HOCM and mitral valve prolapse. This HOCM and mitral valve prolapse, because the left ventricular volume will be also reduced, there will be more systolic anterior motion and there will be more left ventricular outflow tract obstruction because the left ventricle does not have enough volume. So left ventricle do not have the enough volume that it stays stretched. Now the systolic anterior motion mitral leaflet obstructs the LVOT because the blood is not much, so it gets collapsed and comes in the way of LVOT, and thus LVOT murmurs increases. Similarly happens with mitral valve prolapse. So venous return decreases. A2 P2 splitting, because the right ventricular filling is less, the P2 will come close to the A2 and there will be narrowing of that. All the murmur becomes softer except HOCM, which is becomes louder. MVP click comes closer to S1 and murmur becomes longer. Important thing is when to avoid Valsalva. As a doctor, you should know that you should avoid Valsalva in patients of ischemic heart disease and also patients with severe left ventricular outflow tract obstruction. So these are the two contraindications. You should not try to use Valsalva in these patients. Hope you have liked this video. Do comment in our comment box if you have any doubts, and do follow our YouTube channel. Also, if you need any research assistant, our team is completely ready for your complete assistance of research as well as publications. Thank you.